Fitz, could you update us on the most recent evidence on anticoagulation dose, specifically prophylactic versus treatment, and the duration of therapy for COVID-19 patients?
Sure, I'd be happy to. So initially when COVID-19 came out, we were following D-dimer levels. And at our institution, we would initiate intermediate prophylaxis, which is the terminology now being used in literature. So that our dosing was enoxaparin 0.5 mg per kg subcutaneously Q12 hours, or heparin 7,500 units sub-Q Q8 hours in patients with renal dysfunction. And so if they had a D-dimer greater than 3, we would initiate that. And then the tune kind of changed at our institutions to anyone in the ICU, because at that point, the patient was becoming more hypoxic and requiring probably more oxygen requirements than on the floor. So our floor patients, we kept on standard prophylactic dosing with enoxaparin or sub-Q heparin, but then in our ICU, we would then do intermediate dosing. If the patient was already on a DOAC or therapeutic warfarin or even enoxaparin for something other than being in the hospital, we would continue that, and that would serve as their DVT prophylaxis. If the patient did develop a DVT, PE, or even atrial fibrillation and had a CHA2DS2-VASc score of greater than 2, we would initiate therapeutic anticoagulation. Recently, within the last couple of months, some literature has come out looking at both standard prophylactic dosing versus intermediate dose for severe COVID-19 patients. And the first trial, the Inspiration trial that just recently came out, kind of sparked some interest of, well, the outcomes in that trial showed no difference in 30-day mortality or development of thrombosis in patients. So then the question needs to be asked, do these patients need to have an enhanced prophylaxis while they're in the ICU? A recent study just published on July 8th, looking at something similar to the Inspiration trial, came up with the same outcomes. The fact that in hospitalized adults with severe COVID-19, standard prophylactic dose and the intermediate dose of enoxaparin did not differ in preventing death or thrombosis at 30 days. So now the question remains clinical judgment. Is your patient so hypoxic that maybe you feel like they need a higher dose of prophylaxis? And I think that could be argued either way. Treatment dose, on the other hand, I would reserve that for patients that do develop pulmonary embolism or a DVT, or even for AFib, or even acute coronary syndrome if that ends up happening while they're in the ICU as well. And then obviously, if the patients are not able to use any of the pharmacologic therapy, using your non-pharmacologic therapy, such as your sequential compression devices or TED hose or whatever you use at your institution for that. But I think this area gets a little tricky. The question is, if they are receiving an enhanced prophylactic dose or intermediate prophylactic dose, when do we back down just to the standard dose? I think that's also clinical judgment based on lab values. Is the patient getting better? Are their oxygen requirements decreasing? So that may be a conversation that you have on each patient individually at the bedside when you're rounding on them to determine what might be in their best interest.